Good evening. My name is Thomas Danne. I'm very happy to host the Advisor Academy tonight. I will talk about SGLT inhibitors, sodium glucose transporter. This is actually a misspelling here in the title slide, and technology. To start this off, I just want to kind of focus on the unmet need that we're having currently in type 1 diabetes. For some time, of course, we were very much focused on all the issues of microvascular complications as a consequence of poor glycemic control, only to understand that many of our patients are, in the daily basis, really being very concerned about glucose variability and the many issues that come from this. Another factor actually is the consequence of frequent hypoglycemia, being that you have an extra intake of food leading to overweight and obesity, that approximately 60% of all adults with type 1 diabetes are actually overweight and obese. These are really new developments. And of course, we have to see that the long-term prognosis is not so much determined by the microvascular complications, but rather by macrovascular complications. So hypertension, cardiovascular disease, and eventually heart failure are things that we really need to consider in the long-term outcome of patients with type 1 diabetes. Now, if we look at what we're able to achieve, there were just recently a publication of very sobering results from the Type 1 Diabetes Exchange, a registry in the United States. Clearly, a minority of individuals are able to achieve those goals that we set forth, and particularly in the young adult age group, there is a very, very big difference in targets and the actual achievement. And it's not limited to the United States. Similar data has been reported from many other places in the world. And also, the risk of a high A1C was associated with a higher risk of DKA, and actually in a very recent result from PETUS in a different US American registry, high A1C was also associated with a higher risk for hypoglycemia. Now, you could say, well, maybe technology is going to solve all that. But clearly, if we look in the American registry, there is, despite the lack of an improvement of A1C, we do see a huge increase in technology. So I would be the last person to say that technology is not really doing its job. I clearly can say, yes, technology has really made a major impact also on improving the situation of patients with type 1 diabetes, but this technology has to be accompanied by education and also help in interpreting the values, because otherwise sometimes it might lead to a frustration because people don't know exactly what to do with the values, and this then in turn could actually even lead to a worsening of glycemic control. So the good news is that actually the A1C levels were associated with higher use of CGM, was associated with a lower A1C. So yes, there is clearly an indication that technology improves the outcomes, but nevertheless, we would have expected a much better result with this huge increase of CGM over time. So we are in a situation where we really have to do something. And so maybe new treatment approaches are necessary. And you might be aware that in type 2 diabetes, the SGLT2 inhibition has been extremely successful in improving outcomes, in particularly the cardiovascular outcomes of type 2 diabetes. And very recently, from the results from the in the ESC Congress, the Cardiologist Congress, has shown that a similar improvement in terms of heart failure, and this was just published in the New England Journal of Medicine, was also associated in people even without diabetes. Now, if we say, well, there is an improvement in patients with type 1 diabetes, type 2 diabetes, there's an improvement of outcomes in patients without diabetes, looking at those patients who have a very high risk for cardiovascular disease, which is patients with type 1 diabetes, it's kind of difficult to believe, although we don't have the data yet, that this wouldn't also hold true for patients with type 1 diabetes. There are different approaches. So the most usual approach is inhibiting only the SGLT2 inhibitor, which is predominantly expressed in the kidney, and thereby inhibiting the reabsorption of the filtrated glucose from the urine, thereby leading to a higher excretion of glucose through the urine and lowering the blood glucose without increasing the risk for hypoglycemia. There is one drug, sotagliflozin, which is not a selective, but actually a dual inhibitor, which also inhibits locally the SGLT1 transporter in the intestine. And this transporter in the intestine is actually important for the glucose and galactose absorption. And if you inhibit it with this inhibitor, then this means that the glucose then moves down in the intestine from the proximal to the distal intestine, and the postprandial glucose rise is blunted. It still is absorbed, so it doesn't really mean that the glucose is not entering the bloodstream, but it is delayed. The absorption is delayed. And at the same time, we see an increase in the levels of the incretins and PYY, which is an important satiety hormone. So there might be an added benefit, particularly for patients with type 1 diabetes, who are known to be particularly prone to postprandial glucose excursions. So overall, we have three major programs, study programs of three inhibitors. Two of them are selected inhibitors, which is the EASE program for empagliflozin, the DEPICT trials for dapagliflozin, and the INTANDEM trials for sotagliflozin. The canagliflozin program in type 1 diabetes was stopped, and the reason that it was stopped was that there was a notice of a higher incidence of DKA, of diabetic ketoacidosis, and I will get to that in a moment. In Japan, we also have ipragliflozin, which is a study there and actually also has received regulatory approval. And speaking of regulatory approval, two of these drugs have received regulatory approval from the European Medicines Agency. The first one was dapagliflozin, and the second one was sotagliflozin. And empagliflozin presently is still in the regulatory process. None of these drugs have been approved by the FDA so far, and the approval of the European Medicines Agency is limited to those patients with an elevated body mass index above 27 kilograms per square meter, indicating that this is probably a high-risk group for cardiovascular disease, and therefore it might be a good starting point to get some experience in patients that are particularly prone for cardiovascular disease. I will touch on that in a moment. Now let's look at the different studies. You see here the INTANDEM trial, the DEPICT and the EASE trials. You see that the number of patients on placebo on different doses were pretty substantial. And you also see that there is a difference between the INTANDEM programs and the DEPICT and the EASE programs with regard to the baseline A1C, because in the INTANDEM trial, there was a very vigorous insulin improvement scheme with a monitoring committee, so that before entering the SGLT2 inhibition, it was made sure that optimal glycemic control with insulin was reached, while the two other programs looked more like the real world place where, of course, there is always some room for improvement with the insulin therapy. There's also another important point to see in those different programs that you might note that in tandem and DEPICT has a high and a low dose, and the EASE-3 program has actually a very low dose with 2.5 milligrams, which was actually on the recommendation of the FDA that wanted to have also a very, very low dose to see where the risk-benefit ratio actually is. And here are the results in terms of the A1C, which is, of course, the most important and most relevant outcome in terms of the regulatory approval and also a surrogate marker for the long-term benefit of such treatment. And again, please see that the end of treatment values of A1C are a little bit different, which of course has to do with the different baseline values and the insulin optimization there. But overall, you can see there's a clear class effect that all of these drugs have a benefit of A1C improvement, placebo-corrected, approximately up to 0.4, up to 0.5% A1C. The 2.5 milligram dose of empagliflozin is a little bit less, so but still there is close to 0.3% improvement in A1C also with a low dose. Now, is A1C really the big story? And clearly, we all know that if we look at the glycemic fluctuations, they show us quite much more than the A1C, and the A1C not necessarily reflects time and range, and there has been already another advisor academy on this theme. So very clearly, I think with the use of technology for continuous glucose monitoring, we have more and more data available on the importance of high glucose variability. And of course, we need now to look how can we actually improve this glucose variability, although there's still some controversy with regard whether the high glucose variability in the long term is actually contributing to the development of complications. I might just stop here for a second because, of course, there's always a question, when can we ask questions? And now that I think we have quite an audience here, I just want to point out that at the end of this talk, you can submit your questions in writing, and I will be happy to answer all of the questions at the end of my presentation, which is going to last maybe something like 40 minutes. Okay, so glycemic variability. And now how would we see glycemic variability in terms of the patient experience? Here you see a kind of complex picture, which is just trying to tell you that yes, glycemic variability is influenced. There are behavioral changes which are associated with high glycemic variability. Depression, anxiety, even a decline in cognitive tests is associated with increased glycemic variability. Absenteeism of work has been associated with glycemic variability. So overall, this all leads to stress. It leads to problems in the management of the disease and can actually lead to DKA, to hypoglycemia, to persistent high A1C levels. So the daily fight against glycemic variability is really in the center of many of the patients' lives. And so it is really relevant now that we're able to quantify glycemic variability much better with technology to find good new treatment approaches. And number one, here I show you as an example of one of the drugs, which is sotagliflozin, that it actually is able to have an effect on hypoglycemia, particularly in those patients who are particularly prone to hypoglycemia due to a low A1C. So here you can see that both for the level 1 hypoglycemia below 70 milligrams per deciliter, as well as for the level 2 hypoglycemia, which is more clinically relevant, below 54 milligrams per deciliter, you can shift the curve between A1C and incidence of hypoglycemia to the left, so that the hypoglycemia rate with such a SGLT2 inhibitor is actually much lower at the same A1C, so that actually you can intensify the insulin therapy quite a lot. Excuse me. Excuse me. Now, in relationship with the body mass index 27, how we actually have the approval in Europe, you can see that this holds also true for those patients who have a higher BMI and which have gotten regulatory approval. And if you may, it's certainly not less. It's highly significant, both for the 200 and 400 milligrams dose, also in these obese adolescent adults on the SGLT2 inhibitor. And here we see the total population so that you get an idea what really the improvement is. And the highest doses was up to 3 hours, 2.2 hours, 49 minutes improvement in time and range compared to placebo. And still the lower dose had an improvement of a little bit more than 1 hour versus placebo. There was no change in hypoglycemia, but you have to appreciate, of course, we have an overall lowering of A1C, and usually whenever you had a lowering with A1C, you would have had an increase in hypoglycemia, and that is not the case with, in this case, sotagliflozin. Looking at the same data for dapagliflozin, which is the selective SGLT2 inhibitor, which is also approved for body mass index above 27, you have a similar picture. Again, it's 2.4 hours with the highest dose improvement, and it's 2.11 hours with the intermediate dose, more time range, and again, no change of hypoglycemia. So technology really shows how the benefits of this new type of therapy actually play out. And now finally, the EMPA data, again, a very similar picture, improvement of time and range with the two higher doses. There is also a tendency of an improvement in the 2.5 in the very low dose, but although it didn't reach statistical significance, this was, of course, only a little bit smaller group here of patients, so there might be a dose effect as well. And looking for the time in range, actually in the highest, so the improvement of time range, I showed you the total group had an improvement of approximately 2.5 hours, and here in the obese subgroup, the improvement of time range with a high dose was even 3.5 hours more time and range. So now that we have looked into all of these issues of potential benefits we have with the SGLT2 inhibitors, we also have to look, of course, in the risk. And there has been much discussion with the risk of DKA, and I want to really stress the points how technology can improve the recognition of such a risk, and also give particularly some information what we shall do patients using technology, particularly insulin pumps, what we can do if they want to start an SGLT2 inhibitor, what to do to actually mitigate this increased DKA risk. There's also a risk of mycotic infections. This has very rarely led to discontinuation of the treatment and appears to be quite a manageable condition. Now, before I go into DKA, I want to state that really the benefits although maybe the improvement is not so big, but you really have to see the whole picture that is actually happening here. That it's not only a significant A1C reduction, it's not only that there's no glycemic pressure lowering. I showed you that there's weight reduction up to 3 kilograms less weight in the patients. And overall, there was in all the programs evidence of an improved quality of life. So really, although the single benefit might be not a huge one, I think the multitude of these several meaningful different improvements really show a clear benefit of this treatment. And so we need to do everything which is in our power to mitigate the risk, in particularly the risk of DKA. I don't want to go into the biochemistry, and I think probably the biochemistry is not completely elucidated as of yet, why the SGLT2 inhibitors lead to an increase in ketone levels. And this increase of ketone levels, of course, leads to an increased risk of DKA. But only to focus again on what is important to get rid of ketones. It's not only insulin, but it's of course first and foremost insulin, but it's also glucose. So the old German professors always said, the ketones are burning in the fire of glucose, meaning if you have glucose and you have insulin, and this metabolism essentially leads to a metabolism of ketones, and then the ketones are cleared from the circulation. Now, we have to appreciate that there are different programs, and it is very difficult in looking in these three different programs to make comparisons. And we have to understand this, those are not head-to-head trials. You see, all of these ketone levels in the different programs were adjudicated, and the adjudication was different. So yes, all of these programs showed an increase, except for the low dose of empagliflozin. And this is why Boehringer is going forward to ask for the low dose in type 1 diabetes. Looking at the overall picture, here is the meta-analysis, and you can clearly see that there have been different trials, and apparently it really is a class effect that the placebo shows a much lower risk for DKA, and actually the DKA risk is increased with all of these new agents. We have to realize that through the mechanism of action, there is one particularly new thing to learn, both for the patients as well as the healthcare professionals and of course the treating diabetes team. Because if you are taking an SGLT2 inhibitor, you have to no longer rely on glucose as the warning sign for something going wrong, for an insulin deficiency. You can see here with the SGLT2 inhibitor canagliflozin, on the left side, if you are actually withdrawing insulin, when the basal insulin therapy was discontinued in an insulin pump treatment, the glucose goes up when you don't treat with canagliflozin. But if you treat with canagliflozin, due to this increased glucoronary excretion as soon as you're over the renal threshold, you do not see a further increase of glucose, while of course the ketone levels as a consequence of the insulin withdrawal are still increasing. So we are speaking of either atypical DKA or euglycemic DKA. Well, it's certainly not completely euglycemic. There is a little bit of an elevation of glucose, but our old rule, start testing for ketones when your glucose is above 250, does no longer hold true when you are using such an agent. So we have to stop using glucose in our diagnostic scheme for DKA. It should rely on ketone levels and clearly blood ketone levels, because they are measuring beta-hydroxybutyrate, which is the meaningful metabolite, is much quicker, much to the point, and also shows an improvement, the resolve of the situation much quicker than acetoacetate, which is measured with your urinary ketones. So blood ketone is clearly the way to go, and I will go into this in a moment. As we are seeing that there are several benefits of such SGLT treatment, and on the other hand, we appreciate that this treatment puts patients at risk for DKA, we need to find ways how to mitigate the risk. And this group of authors from all over the world actually came together because they had experience with off-label use, and in particular because they participated in trials. And this was then on the title page of the recent diabetes care issue, showing what all of these people around the world came up with for good recommendations. And I want to go through them with you now step by step. So most importantly, we have to find the right patient for such a treatment. Obviously, this is approved only for adult patients, so you have to be above 18 years of age. You have to be collaborating with the diabetes team and perform all the prescribed diabetes self-management tests, and in particular, you have to have received education in ketone testing and interpreting those results. Of course, you need to have ketone testing materials at home readily available. And if you have elevated values, you need to be able to get in touch with your doctor. As we know that the use of illicit drugs increases your risk for DKA, those would not be ideal patients to put on such a drug. Same goes if you have impaired cognition, or if you are pregnant, those would of course not be patients that would be eligible. So there is clearly a kind of a checklist where we would say, okay, so in Europe, obviously you have to have a body mass index above 27, you need to have a eGFR above 60, and we have to make sure that you are able to monitor the ketones. So my suggestion would always be, even before starting a SGLT2 inhibitor, you should give the patient material for blood ketone testing, and he should show you 1 week of ketone measurements so that you have kind of a baseline. And this will also help you to identify patients that you weren't actually aware that they are not the perfect patient. So for example, a patient who is on a low ketone, low carb diet will then show up with high ketone levels. And in order to elucidate why this is a patient with high ketone levels, you will actually find out that this is a patient on a low carb diet, and then advise them against using an SGLT2 inhibitor, because that will otherwise, again, increase your risk for DKA. So if this patient has obtained several baseline ketone levels for 1 to 2 weeks and is familiar and understands how his behaviors and circumstances affect those levels, then he might be an ideal candidate for treatment, unless there are all these issues that have been identified as potential problems in terms of using SGLT2 inhibitors. So for example, as I mentioned before, caloric restriction, a history of DKA, already elevated baseline ketone levels, or having in Europe, that would be the low body mass index, because in the beginning, that was considered to be not the ideal patient, because low body mass index is probably also associated with a lesser cardiovascular risk, and maybe also a lower insulin dose, thereby having less room for safety in case that you are doing a dose reduction and you might end up in a DKA. So if we look at the cornerstones, in addition to selecting the right patient, this would be, of course, also patient education. I will come in a moment to a patient education program that we have. Of course, we also have to educate the healthcare teams, the clinician, and they also need to understand all these issues that I'm sharing with you right now. And yes, there is also a program in development for healthcare professional education. And we need to communicate this risk, this added risk of DKA, and the principles of treating and recognizing DKA in patients that are under treatment with SGLT2 inhibitors, also with the community at large, the emergency physicians. So there has to be adequate product labeling, website information. So I'll share that with you in a moment. So, for example, here is, I apologize that this is in German, but this is what AstraZeneca has developed for their dapagliflozin program, a physician information card, which contains a checklist. All these things that I've mentioned to you right now, the doctor can check off to make sure that he hasn't missed anything. It gives him all the background information. It gives him also a clear scheme, which I will go through with you in a minute, on the levels of ketones and what to do there. How to adjust the therapy is in there. Similar, this is now the patient information material. Again, it gives information on how to recognize potential problems, and also how to interpret ketone values, and includes a clear DKA management plan, which can be individualized to this patient so that he knows what to do if he's measuring elevated ketone levels. And finally, there is a patient alert card, a wallet card, which this patient should, of course, carry with him. So whenever he is admitted due to an accident or things like that to the emergency room, that the emergency room physicians understand what the particular problems could be with euglycemic DKA, what the principles have to be in treating and recognizing DKA in patients with adjunct therapy of SGLT2 in addition to insulin. Now, where is all this material that I'm telling you, where can we find a lot of that? We have put it on the ATDD education website. There is an education portal. Some of these things will appear there only in the next couple of days, but of course there's always a kind of approval process which takes some time. You see here that the healthcare program and the patient education program, they will be translated. The patient education program, 12 languages totally until the end of this year. The healthcare education program, there will be slide decks in English, German, Spanish, Italian, Swedish, and Danish, downloadable from October 1st. So please visit the ATDD education website to look into all these materials, which are available freely for download. And just to give you a glimpse of this new structured patient education called Keto Aware, developed by Bernd Kulzer and Dominik Ehrmann from the Bad Mergentheim group in Germany, from the Diabetes Center there. It gives you a full ketone education, not only for patients on SGLT2 inhibitors, but both for pump, for adult patients with injection therapy, as well as those on SGLT2 inhibitors. So it's a type 1 education. You can see here, for example, patients using technology, using pump technology, make them aware that a silent occlusion can occur. How do you actually recognize the consequences of a silent occlusion early on? What else can lead to elevated glucose levels? How the typical signs of ketoacidosis should be recognized, And then, of course, what is different if you are under a SGLT2 inhibitor. And really the most important cornerstone here is the for-cause ketone monitoring. So it's not that, if you always would measure it in the morning, this is not which really gives you this added layer of safety. The added layer of safety comes that you have the ketone strips readily available, and if you feel unwell, if you have nausea, vomiting, if you are all of a sudden exercising a lot, if you have to undergo a procedure, those are the moments where you should do ketone monitoring and then take the appropriate steps I'll get into in a second when you see elevated values. And here is the first glimpse of the health care professional education program. Again, it's a modular program telling you all about these of DKA when using an SGLT2 inhibitor in patients with type 1 diabetes. So kind of to focus on these things, we need to know the risk factors that are associated with an increased DKA risk, which is of course insulin reduction, which would be insulin pump or infusion site failure, very important for all those techies in the diabetes field here to understand that. Alcohol, illicit drugs, extreme physical exercise, vomiting, intercurrent illnesses, but also travel with a disruption in the usual schedule of insulin regimen. We really have to be very cautious there. And inconsistent caloric intake would also be a lower risk factor, but also a risk factor there. In some programs, female sex also came out as a risk factor, potentially because female patients with persons with diabetes more frequently have eating issues. So now, how should we mitigate the risk when we want to start an SGLT2 inhibitor? So you will always start, of course, with the lowest dose, and you won't start it when you have already at baseline elevated SGLT2 level, ketone levels. You will not start it in a patient who has a history of DKA. So you will wait really if he has 6 months, better 1 year without DKA, and that when there was a DKA issue, this has been completely resolved. Insulin pump use of the obvious reasons. I think on the one hand, it also gives us some confidence, because in the early days, insulin pump use was also associated with a higher risk for DKA. And we all know now that registry data is actually telling us that patients with insulin pumps have a lower risk than those with MDI for DKA. So I hope this is a model for the SGLT2 use, that yes, we have a higher DKA risk in the beginning, but hopefully we will be able to mitigate this risk, that eventually the DKA risk on those patients, selected patients for SGLT2 use, will be actually lower than in the background population. But this still needs to be proven. So very important, these issues where you would consider that you are at a higher risk of DKA after a set change, so maybe 4 hours after changing an insulin infusion set, you should plan to do a blood ketone monitoring just to make sure that the set is working. You should have, as I mentioned now several times, the blood ketone monitoring equipment available, which is leading to a reduction of the insulin dose. You should be very cautious. So these additional considerations for patients on pump are, as I mentioned, with changing pump materials, but also whenever you have any suspected insulin interruption, when you have an unexplained high blood glucose value, then it would probably be very prudent to stop the treatment with the SGLT2 inhibitor, which is always a good suggestion. And I think the phrase to memorize is, when in doubt, don't take it. So if we are starting SGLT2 inhibitors, reduce an insulin dose cautiously in patients who have a very tight glycemic control. You may want to reduce a little bit the prandial dose after start. This really depends on the way of glycemic monitoring. Certainly, a patient with an A1C above 8 probably will not need such a step. Then you have to monitor the glucose levels and then adjust the insulin dose accordingly. But particularly the reduction of the basal insulin, you should be a little bit on the cautious side because this, of course, is kind of protecting you of ketone production. So the continuous optimization of insulin dose is, of course, something of very big importance. If you are encountering hypoglycemia with SGLT after starting SGLT2s, then you know, of course, you need to adjust the dose, but do this in small steps. And if you really, out of what reason whatsoever, need to reduce the insulin dose quite extensively, then you should consider stopping the SGLT2 inhibitor insulin dosing. Whenever you hospitalize a patient, whenever he is hospitalized, he needs to know that he should stop the treatment for major surgical procedures, any acute medical illnesses. You should certainly consider this. And now I'm coming to, again, technology playing a big role for the safe use. And we really have to understand this for-cause blood ketone monitoring. I show you here three different methods, three different devices that are used for ketone monitoring, particularly the Libre is quite prevalent in Germany right now in people with type 1 diabetes. And this also offers the possibility of ketone monitoring with the same device. And again, you have to reiterate to your patients, whenever you feel unwell, everybody around you might actually have eaten the bad pizza, the bad fish, but for you, you have to make sure that it's not DKA. You need to test your ketones to make sure whether it's really the bad fish or whether it's really a diabetes management program. How about urinary ketones? Yes, I'll show you in a moment. Of course, you can also measure urinary ketones, but as I mentioned before, you will have a delayed diagnosis and you will also delay any detection of a resolvement of the situation. But of course, urinary ketone monitoring will also help to detect an issue. And here are the cut points. So basically below 0.6, no action is needed, everything is fine. 0.6 to 1.5, you have to already start doing something. And as I said before, it's glucose plus insulin. So yes, if you have a high glucose value, you might only need insulin. If your glucose is near normal, you might want to eat or drink some carb-containing fluid and give an appropriate insulin dose, and then check your blood and urinary ketones to see which direction everything is going. Is it above 1.5? Well, then you really need to consider taking immediate medical attention. And if you have a level above 3, then you are probably already in DKA. Now, how does it relate to the urinary ketones? And here I show you the way that you should use the different thresholds. If you have trace or small, again, you should then really start a treatment to get rid of these ketones. If you have a moderate increase, then of course you should consider seeking immediate medical attention, particularly because the ketone levels in the urine are usually a little bit lagging behind. And of course, if it's a large or very large ketone excretion, you probably should seek immediate medical attention. Now, if you see these elevated levels, what is the kind of the best strategy? And I think um, in short, follow the stitch protocol is maybe what you can tell your patients. So ST stands for stop the inhibitor for a few days when you're in a problem. So really, when in doubt, don't take it. Then, of course, insulin administration is important. And if the glucose is not high, the insulin administration has to be accompanied with a carbohydrate consumption. And I guess for patient education, this is really the most difficult thing because it is counterintuitive. If you feel nausea, if you feel that you're sick, the last thing you want to do is eat something. But you need to take in carbohydrates and you need insulin. And only with those two things you will get rid of it, because again, if you feel bad, you say, well, I won't want to eat. I won't, because I don't eat, I don't take insulin. And then of course, you're downhill and you won't have a chance to get rid of those ketones. And finally, you also need to have adequate hydration. So water or non-caloric athletic drinks with balanced electrolytes would be another option here. Finally, kind of as the way to the future, I want to share some previously or currently unpublished results, which we hope to submit soon, where we looked under the conditions of our research unit on what does actually happen if you have somebody on a closed loop control with unannounced meals on an SGLT2 inhibitor compared to placebo. So do we really need an SGLT2 inhibitor with current MD logic closed loop approaches? And this is the way that we did it. We gave them dapagliflozin twice daily. We had standard liquid meals, and all this under automated insulin delivery. And you could appreciate, of course, those mixed meals are something like a oral glucose tolerance test to some extent. But you see that the blue line with dapagliflozin not only has a much lower level overnight already during the fasting state, but the increase is lower in the unannounced meals, the glycemic variability is lower, and the levels return to normal much quicker. In numbers, we have the same 3 hours more time in range like we had before in those large clinical trials with both MDI and pump patients. So yes, even in patients with a closed loop, we will be able to see benefits with the SGLT2 inhibitor treatment. And although this couldn't reach statistical significance, but if you look at the average time and range overnight by 100, lying at 100%, I think that's really, again, quite impressive. So to sum up my talk, and before you might have, maybe, you know, nearly 100 years ago, the first patient with insulin was treated with insulin. Yes, pramlintide has been improved in the United States as another treatment option. In Europe, we do not have any other treatment option. And I guess now we have one, and in my mind, the new horizon for patients with type 1 diabetes may very likely be achieving more time in range with a combination of closed loop automated insulin delivery and adjunctive therapy with SGLT2 inhibitors. And I want to close this evening talk, the Advisor Academy, with a big thank to my team in Hanover, which is doing such a fantastic work and doing all these research studies. So I'm looking forward to your questions. Thank you very much for your attention. So I don't see any questions yet. Um, Of course, I'm happy to answer any questions that you would send me by email. My email is easy to find on Google, so happy to address those if you need other ways to answer those questions. Oh, there's a question. Okay. So what is a closed loop? Yes, thank you for this question. I should have described it a little bit better. The closed loop is when you're using, on the one hand, a continuous glucose sensor, a subcutaneous glucose sensor, which is measuring the glucose continuously, and on the other hand, an insulin pump, which is continuously delivering insulin. And if you join those two, and this is why it's called closed loop, a loop, by actually measuring the glucose and administering the insulin, and having an algorithm in between, which calculates the amount of insulin which is needed to control the glucose levels, then we consider this a closed loop. There is kind of an intermediate step, which we call a hybrid closed loop. This is where we are currently with our research, meaning that you still need to announce meals, because this is something that is very difficult to detect as of now automatically. So, but in the results I've shown you here, this was a full closed loop, meaning that the algorithm had no idea that food was coming, the mixed meal was coming, and thereby you could see how the SGLT2 inhibitor actually improved. The next question is, with the increase of hybrid pumps in type 2, increasing the younger type 2 patients, will a specifically type 2 pump population be required for use of SGLT2 as adjunctive therapy? Again, excellent question. Yes, I agree that probably pump use will become more and more important also for patients, young patients with type 2 diabetes. But I think we have no good scientific evidence as of now how a combination of such a pump in patients with type 2 diabetes is going to be. I know that there are studies underway with a hybrid closed loop in SGLT2s and faster insulin, faster acting ultra rapid insulin. So there are many things that are tested right now, and I'm looking forward to the scientific results. And I would be very careful, as long as we don't have those study results, to recommend these things to individual patients. Are we saying that we should consider SGLT1 patients in patients above body mass index of 27, but not in those under? Again, a very good but very difficult question. Clearly, the regulatory approval at this point is only for those above a body mass index of 27. You can discuss quite a lot on the scientific grounds of this recommendation. I think it's a little bit clearer for dapagliflozin as for sotagliflozin. But in generally, it shows, yes, we have to balance the risk and the benefit, and certainly such an adjunct therapy is not for everybody. And likely the obese patients with type 1 have a higher cardiovascular risk, and thereby it does make some sense to say, let's start with those patients, gain some experience, and then reconsider whether we should also use it for patients below 27. But clearly the regulatory studies have shown that also in patients below a body mass index of 27, there are considerable benefits, but this is against the regulatory. So, as of now, I don't see any additional question. Okay, so I will I will try to answer other questions that will come in writing, and I want to thank you very much for your attention. It's now nearly an hour since we started, and I just don't want to interrupt any more of your evening activities. And thank you again very, very much for your attention. Have a good time, and I look forward to see you in the next Advisor Academy.